Hey, everybody, welcome back to another segment of Casual Conversations. I'm your host, John Malanca. We also have Jordan Tishler, Dr. Jordan Tishler, our leader and founder of the Association of Cannabinoid Specialists. We have Dr. Abodeely and Dr. Sandra Carrillo. This topic actually is really geared towards you. We've always talked about cannabis and the medicine, cannabis is medicine and benefiting the patients. Let's take it from the other side of this topic, because we always get quite a few of our doctors that are members of the Association of Cannabinoid Specialists. And so if you're a doctor out there, we'd love to have you join. But the topic comes up quite a bit is how to speak to my patients, because a lot of times we hear the patients saying, I talked to my doctor and it's like deer in the headlights. One, they don't know about the endocannabinoid system, or two, they're afraid about their license. And so the three of you being medical professionals, maybe you can touch up on that, but how to speak to your doctor. And so you were three well-educated specialists. Adam, you work with patients as a surgeon as well. And this topic comes up. Do I need to stop my cannabis right before going to surgery? 24 hours or a week prior? And so can you share some of the things that how you speak and break the ice with your patients? And are these patients something that you recommend cannabis to the patients that have never tried cannabis, but you feel that this might be an extra modality to help bring their body back to balance? So
yeah, no, it's a great point and certain topic to discuss. And we've certainly seen an evolution, I think, over the past several years of interactions between doctor to doctor, between patient to doctor, is just about cannabis. It's a lot easier now than it was several years ago. But when I see basically two large groups of patients, some that are coming to me specifically for cannabis. And those conversations are very, much easier to have. I don't need to convince them. They were either referred by one of their specialists, one of their primary care physicians, who aren't trained in cannabis medicine. So that's one, group of patients. But then the second group of patients are people who come to me for, obviously surgical problems, but then I also treat a lot of medical GI problems as well. And cannabis is never one of the first things that I recommend, because it's not our classic training. And of course, our data and science around cannabis for particular GI conditions may not be quite as good as it is for some of our other conventional pharmaceuticals. Having said that, we have standard recommendations that we'll make when people are we'll present with different conditions. Let's just take irritable bowel syndrome. I think that's kind of a classic example. And when patients come in with seeking relief from their irritable bowel symptoms, we have standard workups to make sure that it's just irritable bowel syndrome and not something like inflammatory bowel disease or another, infection or condition, which, might not just be, your standard irritable bowel syndrome. But when people go through this, most people we'll trial them on, the standard things, whether it be, dietary modifications, lifestyle modifications. And, and for something like irritable bowel syndrome, we have about 20 different medications right now. And the reason is because not one medication works for everybody. And that's where cannabis becomes just another tool that I tend to use. So I always ask if people use cannabis. If they use cannabis and they have IBS, then they're seeing me, then clearly either the cannabis isn't working for them or they're not using it in a way that would be beneficial to them. So I'll typically go through some of our standard recommendations, and after our patients come back to the office one or two times, if they haven't brought it up, that's when I'll then start to introduce, hey, have you ever thought about cannabis? Have you heard anything about cannabis? Do you know anybody using cannabis for your types of symptoms? And, and then I kind of just wait to see what the response is. And sometimes people immediately say, oh, I thought you'd never ask. I knew you did that, but I didn't want to bring it up. So clear, so the icebreaker's gone, and now we can have a frank discussion about it. And some people are, completely, naive. They've heard about it. And so that's where then I just have to kind of go into a little spiel about cannabis, what it is, how its role that it currently plays, and its role that it might be able to play for that particular patient for their particular condition. Early on, I will tell you that I had a lot of patients who would come to me requesting cannabis, and if there are particular conditions, whether it be something like seizures or pediatric condition or a neurologic condition, that's not my area of expertise. I always do this in conjunction with that specialist. And so, yeah, now early on, there weren't many people that wanted to refer for cannabis, particularly to a surgeon, so, why would a neurologist, who a patient comes who's interested in using cannabis, maybe if it's just CBD for seizure disorders, and, having them say, hey, I've got a surgeon I'm going to go send you to talk to you about cannabis is, not an easy sell. But early on, there were a lot of patients who were forced with some tough decisions, meaning your doctor is not going to continue to see you if I certify you for medical cannabis. You have some tough decisions to make. And there were several patients who left their providers for another provider who was, more open to it. And over the years, I would say majority, if not all of those providers have come full circle and now are much more open to cannabis as an alternative option or as an adjunct option. And a lot of times it's a lifeline for some of these other specialists too. If people have tried a lot of things, I get referrals from other gastroenterologists who said, hey, I've tried, this person for whether irritable bowel syndrome, whether it be inflammatory bowel disease, and they say, hey, I've tried everything, they're interested in cannabis. Can I send them your way? Sure. So, there's lots of nuances to this, John, but we have come a long way. And I think, honesty is always the best approach.
We have come a long way, and the stigma is still there, but it has dropped dramatically from where it was a decade ago. But I do agree with you on the icebreaker, because a lot of the patients I work with, unfortunately, are afraid to bring this topic up with their doctor for that exact reason of seeing his or her reaction to that. And so having that bright icebreaker, they clearly trust you as a doctor coming in there. And so having that camaraderie with the patient is very nice. And so, Dr. Carrillo, do you want to add to that with your expertise? I know you're traveling the world speaking on a regular basis on this topic. And so I'm certain you've seen and heard a lot with your patients as well as other doctors that you speak with.
Yes, this is very important. We've had a lot of patients, as Adam said, that they are coming, usually asking for cannabinoid therapies, not like the vice versa, that we used to be the ones telling the patient, take this antibiotic. This is the opposite. Now the patient is coming to the clinic saying, please, can I have cannabis? So first, the initial approach is, of course, put together a plan for the patient, a clinical record, see all the comorbidities, medications the patient is taking. Stigma, as Adam is saying, still there, but I think little by little, the patients are more aware that this is a medicine and is being legal in some countries, particularly in the country I work is totally legal medical cannabis. So the most important thing for me is to make the patient to realize what are the expectations the patients have from the treatment, because sometimes they coming thinking that it's going to cure cancer and it's going to cure pain and it's going to cure everything. So as Adam said, if you're honest with the patients and you know what is the purpose of the treatment, what are the objectives of the treatment, it's better to have the patient knowing all this since the first very moment that comes to your consultation. So tell very honestly what extent is the medical cannabis can help. There is sometimes that I have patients that I have to tell them, sorry, this is not a therapy for you. This is not an alternative for you. Some patients don't like it, but you have to be honest and say it's not for you. We're not trying to sell anything. First the principle, do not harm. So what we think where the patient benefits, we prescribe, but if it doesn't, we don't see any benefits, why would we be doing something like that? So first, the expectations are very important. Explain the patient also the process of titration that is very different than what we used to do. Sometimes the patient gets impatient because he thinks with the first drop under the tongue, he's going to experience total relief. So you have to explain them that it's a process of titration, could take 1, 2, 3 weeks. And according to all those explanations you give the patient, you are more likely to achieve a successful treatment and to see the patient coming back. So that's very important. And of course, the follow-up, I have seen that in order to have a successful patient treatment, you need to follow up your patient, do the consultations, if it's on the phone or presential consultations. It's key to do that and educate the patient also in the first visit. Tell the patient about the side effects, the drug-drug interaction. So that way you build the trust with the patients, and of course, advising the patient what is the product the patient needs to take, where to get a product that complies, that has compliance, standardization in the extent that we can find it, that we know where the patient can get a product that is safe, because what is killing us right now is the mislabeling, the misinformation, the false claims. So if we remain very aware and we explain the patient the danger of buying in the streets with no standardization, with no prescription, I think the patient will really appreciate that.
Yeah, thank you for that. And Dr. Tishler, since you work with a lot of patients, and following up on Dr. Carrillo with the expectations and the consultations you do with the patient, discussing ways of consumption, what their expectation is, as Dr. Carrillo was talking about. Safety is important, but also, do you talk about have they ever used cannabis in the past, and going there? Because I know you work with a lot of patients. You're great at hand-holding patients into this new world for many that have been against it their whole life because of the stigma. And so can you share some of your personal experiences?
Absolutely. You know, the first thing is that I wanted to talk about for a second was this icebreaker that Adam had mentioned. I think that this is that the concept needs another step forward, which is to say that, you know, if Mrs. Jones came to see you for back pain, you have a set of recommendations that you would offer her. You wouldn't expect Mrs. Jones to say, "Doc, my back hurts. What do you think of Tylenol?" Or, "Doc, should I go to physical therapy?" I mean, they might ask that question, but you wouldn't wait around for that. You would say, "Mrs. Jones, I want you to start with some Tylenol, and then we'll refer you to physical therapy. And if that doesn't work, God forbid, then we're going to get you some opioids," right? So I think that the next step for us as clinicians, and I mean this not us, we cannabinoid specialists, but really the primary care folk out there, is to get to a point where cannabinoids actually are part of that algorithm, right? And that it is really our responsibility to slot this medication into that thought process so that Mrs. Jones ends up with the best care available. And that doesn't necessarily mean that I'm saying primary care needs to do this kind of medicine, but rather to say, look, if the Tylenol and physical therapy and nonsteroidals haven't worked, maybe we've tried some Lyrica or whatever, and that hasn't worked. Before I write for the Percocet, I'm going to send that patient to see Dr. Abodeely, right? And then if that doesn't work, then we'll write for some opioids. So I think that, you know, that's really important. And I think the other thing that Sandra had mentioned is, you know, talking about all of the expectations. And what I found over the years is that, you know, patients hear some of what we're going to say. And so when I see patients back, I ask about those, you know, last time we talked about, you know, dry mouth. How's your mouth doing? You know, especially if the patient comes in and they have congestive heart failure as part of the milieu, there's a lot of discussion about how much water you need to take in. So coming back to these things over and over again, a lot of my patients come in and they're smoking, right? And while smoking cannabis isn't the worst thing in the world, I certainly would rather have them do something safer, like vaporizing cannabis flower. And what I find is that many times patient isn't ready for that change. But like we know from the smoking cessation literature, you just kind of bring it up every 6 months or whenever you see them. And, you know, maybe it's 2.5 years later, and suddenly they buy a vaporizer and they're like, "Oh, doctor, I just learned this wonderful thing." I'm like, "Okay, fine, great, do it." For the primary care folks, I think that there are a number of questions that I kind of come up with, you know, that are those icebreakers that lead the discussion. Are you using cannabis in any fashion? For what purposes, right? "Oh, doc, I just really like smoking weed." Okay, fine. That's a different discussion than somebody's like, I'm smoking weed because my back hurts, right? Or whatever. Where are you getting it, to Sandra's point, right? Let's make sure in that harm reduction set that it's not coming from the dude on the corner, right? What forms are you using it in, right? This is particularly important if patients are coming in for medical purposes, right? Somebody comes in with back pain and they're smoking a bowl every 4 hours. That's probably excessive exposure to THC when you could give them a lower dose in an edible form that will cover the same period of time, but you only have to dose it twice a day instead of every 4 hours. How often are you using it? How much are you using, right? In some ways, really, there are two kind of key elements that I would try to identify. One is risky approaches, smoking, vaping oil, dabbing, those sorts of things.
And that pace, more is not always better. So can you talk about that when you're on that?
Yeah, absolutely. And let me come back to that with after this. I mentioned the second point, which is excessive or problematic use, right? I mean, that is to say, cannabis, like any medicine, has a therapeutic window in which it's useful. And then if you get above that, that's not more useful, it's more problematic. It develops tolerance, and from tolerance we can see dependence, and sometimes from dependence we can see, addictive type or use disordered behavior. And our goal in medicine, not even thinking about cannabis as a therapeutic, but just thinking about sort of the public health or the harm reduction side of it, is that if people are going to be using it, we want to guide them towards safer, more beneficial use. And I have patients who come in and they will be saying, well, I'm here because my back hurts and I'm smoking a bowl every 4 hours. And sort of to the example I gave before, I will often then say to them, look, that bowl is probably 75 or 100 milligrams of THC, which is probably more than you need to be using. And using it every 4 hours means that, if your total daily exposure is many hundreds of milligrams, and on average in my clinic, I'm treating somebody with 10 milligrams twice a day. So 20 milligrams total for the day. Maybe it's even double that in some of the, some cases, but it's still 40 milligrams a day and not hundreds of milligrams a day. So looking at sort of what is the purpose here, and are there best practices that not only will achieve a better medical outcome, but do it at decreased exposure and therefore decreased risk, is exactly the name of the game.
Dr. Carrillo, earlier you were sharing, it's not for everybody. And you three as medical professionals, are there ever times that you pretty much will say, I do not recommend this for you?
Well, yeah, a few times I had the patients that I have to tell them no. When you don't have like a clear diagnostic, first you have to just to make sure what is the diagnostic. There is patients that they come like claiming, oh, I have a headache, my back hurts, I have nausea, I have this, I have that. So first time as a doctors and clinicians, we need to have like a clear diagnostic, and then also as Jordan was saying, we need to see if the patient took the steps or did the optimization of the current treatments that we have in the market. And as Adam say, it's not like a first line a treatment. For example, I have a patient that comes and said, oh, I have my child that had a crisis, a seizure yesterday. And I ask, oh, okay, this is a patient that is being treated by a neurologist. Since when it has epilepsy? No, it's the first time. I say, sorry, this is not an indication. It's not for epilepsy. It's for a refractory epilepsy. It has to be a patient that has an history of seizures, being treated with 2 or more medications. So there is not like a particular situation in here that they will let me say to the patient, oh, hey, you had your first seizure, let's give you a cannabis. No, we have to just follow the procedures and the protocols, and as in a lot of pathologies we have that. We have to make sure first what is the diagnostic, And before start cannabis, we have to be clear which one, because there is patients that say, oh, I have anxiety. Well, we have to see what type of anxiety is that you have, or I have an insomnia. So first the diagnostic, and then since we talked before, is not a first line treatment, so we have to use the other resources we have, or if the patient is been having the treatment that is been using is doing like not the proper doses of the other treatment. So I always make sure that the patient optimized the conventional therapies and did it in the right way, and then I make the decision if the patient needs it. But for example, that was one example, patient with epilepsy for first time, first seizure comes and say, I want to start taking cannabis. I said, no, we need to do a complete evaluation. You need to start with the conventional treatments after we have the diagnostic, and it's for refractory epilepsy that we use it. So that's my answer, but it's like a very broad question.
I think that's exactly right. I mean, I can think of a bunch of examples. I had a mom call me up and she's like, you know, my little Johnny's 16 years old and he's really anxious about taking exams in school. Do you think we can give him cannabis so he can? I mean, I'm like, no, this is, you know, like if he has some school anxiety, therapy would be the first step, maybe an SSRI, but you know, like let's just go down the path. There was a case I saw many years ago of a 42-year-old woman who had 2 children under the age of 5 years, and she had developed a particular type of thyroid cancer that was 100% curable by removing her thyroid. She had had half her thyroid removed already by a very reputable surgeon, but there was evidence that there was some in the other lobe that needed a repeat and a complete removal. And she came to me saying, I don't want to have this surgery. I want to use cannabis instead. There's no role for chemo or radiation. And she just needs to have that rest of that gland removed and she'd be fine. And she was absolutely trying to convince me that I should put her on this completely unproven approach instead of this. I said to her, I can't do this. You know, if you take cannabis and this tumor gets out of hand, which it might, you're going to die and leave your children without a mom. But if you go back to Dr. Gawande and he takes out the rest of your thyroid, you're done, you're fixed, have a nice life. And, you know, but she just gets such an earful from the internet and from sort of the advocates, you know, on the whole Rick Simpson thing, and it just isn't related to reality. So we have to step in and kind of be the wet blanket or the source of reason.
And I run into that, you know, with the patients that call or our organization is they think it's because of the media. I mean, it really confuses a lot of people. If you take this, you're healed. And I should never want to give anybody false hope, but you want to give hope. And, you know, earlier you mentioned too much vaping, dabbing, et cetera. And for our listeners, any of the doctors and medical professionals out there, we have discussed cannabis use disorder as well as cannabinoid hyperemesis syndrome, both great topics. And maybe we can touch up on that on another podcast. Adam, maybe we can end with you. You working for an institution in the hospitals, because I do run into doctors that say, you know what, John, I can't even talk about this because of the institution I work for. What can you recommend in helping? Because I do believe you work. I know you do stuff on your private practice, but you have worked for institutions. And what about the fear that's still there and the stigma for medical professionals recommending medical cannabis, and or patients that work for an or doctors work for an institution that said, you know, I don't want that in here, because it's still there. It's still that topic does come up, and I don't know if you run into that in your practice or where you're working.
Well, that's actually one of the biggest reasons I got involved in cannabis is because I'm, you know, I'm in private practice still. I have administrative positions within the hospital too, which fall outside of the jurisdiction of what I can do and what I can't do as it relates to cannabis. And we obviously have done that for particular reasons. But, you know, when New York State legalized cannabis in 2014. And for about a year or two before that, I was counseling patients who were already using it. And when it when it became public knowledge that cannabis was going to become legal for medical and doctors could start prescribing it or certifying patients rather in New York State, I reached out to several oncologists, several pain management doctors, because I had patients who were interested in pursuing it, and to ask them if they were going to be certified. However, they were all employees of the hospital. And right now, because the hospital employees, the hospitals receive federal funding, and as a result, no funding can go towards cannabis care. So at least, in where I live, or I practice, I should say, where I practice in upstate New York, I'm one of 3 providers within about 100 miles that actually do it. And that's because we are in private practice. Now, I don't know whether some people are willing just to take that risk, other hospitals and institutions, but certainly none in upstate New York that I've found have been willing to do it, which, is just an opportunity for private practice providers.
Good. Well, thanks for that, because I know that topic does come up, and thanks for sharing. Jordan, if you want to close it out.
Sure. First of all, let me say, I used to work for the VA, right? And so my private practice, I always say, was not on my bucket list to be in private practice. It is, as Adam described, it became the way that I could take care of people without having to run into the larger institutions' issues around the Schedule I prohibitions. So I think that this is very common. The other thing that we mentioned way back at the beginning here, actually, John, I think you mentioned it, was some of the questions about anesthesia and what recommendations we have. And I just wanted to point out that the Association of Cannabinoid Specialists actually has an entire course on the interplay between cannabis prescriptions and surgical procedures. So if people are interested in that, they should head on over to our website, cannaspecialist.org, and you can get to our learning management system and take that course. It's actually really well done by an anesthesiologist, and of course is all based on data that we have at this time. So thank you everybody for joining us today. I encourage people who are watching to learn more about us. Go to cannaspecialist.org, poke around, read some of our position papers, learn about the resources that we make available to doctors and other clinicians, and please join us.
And when you say join, not only available for practicing medical professionals, but also students. And students join for free, correct? Correct me if I'm wrong.
Students are free. Recent graduates have a reduced price. People outside the U.S., particularly in Latin America and Africa, have a reduced price. So we try to make this a big tent. And the other thing is, it's not limited to physicians or other clinicians. I mean, if there are people out there that are simply interested in learning this sort of thing, dietitians, naturopaths,
chiropractors too. I mean, we're having some chiropractors that are here to join too. So, but I thank you all, Dr. Carrillo. Always a pleasure to see you, Dr. Abodeely. I know you're back and forth between Jamaica as well as in New York, not Jamaica, New York, but Jamaica and New York. And Jordan Tishler, our leader and founder of the Association of Cannabinoid Specialists. I'm your host, John Malanca, with Casual Conversations, and we will see you on our next episode.